General practitioners are the cornerstone of the Australian healthcare system. Can't do effective system change without general practitioners being involved, and they've been key to the success so far of Western Sydney diabetes. And you're going to hear from 3 GPs who are doing different things in this space but making major contributions. Let me introduce Dr. Shanthini Seelan, who's a GP at Bridgeview Medical Practice. Just come up, Shanthini. Kean-Seng Lim from the Mount Druitt Medical Centre, and Prashanta Mallick, General Practitioner at Malters Road Medical Centre and the Barbara Boulevard Medical Centre. Thank you very much to all 3 of you. Being GPs as opposed to non-GP specialists, you will actually know how to turn on your microphones, which is going to be great. Shanthini, you've been involved in the Healthy Living to Gabby. And I talked earlier on about how communities can solve problems. Just get into the detail here. What did you do, and what results have you had?
Thank you, Norman. Healthy Living to Gabby is a community-based organization. We are actually a little fire that was lit by Glenn Mabley. Glenn truly believes it's community all the way. Diabetes is a community-based disease, and it has to be managed in the community. And we thought, and Glenn lit a fire, and he said that, why don't you all gather a group of really interested individuals from all walks of life, all bound with a common goal of bringing up awareness of diabetes in the community. So we have a group of 25 individuals. We meet every month, and all of us have different skill sets that we bring together, and we focus and we work at grassroots levels in the community. And this is what we do. We bring about awareness of community, of diabetes in the community. We are based in Toongabbie. It started in Toongabbie, but doesn't mean that we are just focused there. We look after the whole of Western Sydney, you could say that. And over the 5 years that we've been in existence, we have done so many forums on diabetes, really interesting forums. And during those dark, dark days of COVID, I have to plug this. Thank you, Norman, for CoronaCast. It took us through COVID, and it saved my life, at least. Thank you. Well, during the dark, dark days of COVID, we went on, we started doing webinars, diabetes and COVID, and we had a lot of success, and we reached out to a whole group of people out there who were very, very confused and very scared. And through this method, we managed to bring about a lot of information about diabetes. And we found that when we do community speak, when we speak their language, they listen to us. Our latest...
Because you've been focused on the Tamil community in particular.
South Asian, because when around where we practice, there's a huge South Asian community. A lot of them have recently arrived, a lot of first generation migrants, and a lot of them have refugee backgrounds.
How did you find, it's all very well to have health system leadership. How did you find the community leadership? Because that's the key to sustainability.
Yes.
How did you find them?
How do you mean, like approaching?
The people within the community who are going to lead this and actually almost take over, which is what I assume has happened in part, is that you can step back a little bit and the community is taking ownership.
Exactly. We found that we had a lot of individuals who shared the same ideals as us. We had a lot of, we functioned under the auspices of Western Sydney Diabetes, and they provided a lot of support for us. We wouldn't be here without them. And of course, our PHN. And the best thing is to find people in the community who really understood what was happening. And they joined us. There is no money involved here. This is all a not-for-profit organization. We all volunteer our time. And when we find that when we approach the community, talking to them from their level, they really understand what we do. And our latest forum is called Women's Health and What Men Should Know. It was a terrific success.
Is it scalable? In other words, it's fine. You've got the enthusiasm. Glenn lit the blue touch paper and retired to a safe distance to allow you to get on with it. But is it scalable in terms of the whole of Western Sydney?
Yes, most certainly.
How?
Well, it's just that I can speak for myself, and I think there is a Filipino group as well, servicing the Filipino community, all you got to do is really understand how bad diabetes is, how serious this epidemic is. It's threatening to overwhelm us. Unless we get the community involved, unless we actually reach out to the community, we're not going to win. It's going to be an uphill struggle. So
that drives that community impetus.
The community spirit, yes.
Can the I'm still surprised when I say to somebody who's a GP leader in their practice, so how many people have you got with type 2 diabetes in their practice, and they can't tell me?
In my practice?
Yeah. I was actually moving on to Ken there, to get onto his pet bear, which is data. It always surprises me that I find GPs, but you will find practice managers and people like you who say, well, I've actually got 417 people with type 2 diabetes, and I know what their HbA1c levels are. How critical really is data to all this in the general practice setting?
Yeah, so, I mean, it's interesting because that's actually the question I ask people when I want to know what their practice is like. But 492, 12 of them have an HbA1c greater than 10. Of whom 2 of them are probably for medical reasons, and the other 10 are actually more for patient activation and other reasons, where the most common comorbidities for those other 10 are actually mental health. So about 14% of our adult population have type 2 diabetes. Bit of a data nerd, I don't know how far you want to go.
Well, what I'm trying to drive to here is it's fine to have the enthusiasm of GPs such as you three, specialist general practitioners such as you three, but you need systems in place to actually make this work. So you get community activation, you need the right system. So I'm asking you really, what is the system that needs to be in place in general practice to make this work so that it's easy for GPs to do it rather than hard?
I think that we often think that we have to find new things, but the reality is actually we've got the systems we need. It's about how we use them, rather than whether we don't have them or not. So the data analytics systems we have, and a lot of this is through the PHN licenses and things, are actually very sophisticated as they stand. And they're sophisticated enough to allow us to find the thing which gives that practice team purpose and meaning. So when I refer to the fact that 14% of our patients of our adult patients have type 2 diabetes, that's actually not drives the practice team as much as the fact that when I say 11% of our patient population have a greater than 20% risk of hospitalization in the next 12 months. And we know who they are. And we can work out what combinations of conditions they have, and no surprises. Diabetes is one of the big things, but if you have diabetes and chronic kidney disease, that immediately jumps your risk up by 2 to 3 times, and then we keep adding it in, and we can really refine this one very dramatically. So when it comes under the purpose, the data actually drives that purpose because it's visible, it's dashboards, we can see those changes month by month, and we can actually see it right across the region. And even in fact with things like Glenn's work, we can actually see changes in prescribing patterns as well. So the data does underpin everything, and it drives behavior, but it also acts as one of the incentivizers for further change.
I mean, you and others in Western Sydney have been pioneers in creating, if you like, a new system of general practice, where it always really annoys me where all you ever hear is negativity about general practice, and then you wonder why medical students don't want to go into general practice, because all they ever hear is a moan, and people such as yourselves, all three of you, have this very positive attitude and are changing things. But one of the barriers to change is indeed reimbursement and getting reimbursed for this. So some of this is out of the goodness of your heart, and you want to do a good job. Moving forward, what needs to change in reimbursement so that there are financial incentives for GPs who may not be connected right now?
So you've come to really the third element of what I would see, which is raise, train, sustain. And sustain is how do we keep this system going on? Reimbursement is central. Part of it is actually recognizing that the traditional way of doing care, which is one-on-one, one patient, one clinician, is not necessarily the only way nor the best way. Second thing is recognizing that a lot of the work is actually behind the scenes. So reimbursement does need to have a couple of elements. One of them is how do we support the behind the scenes work, the data governance, the data improvement, the systems improvement. But the second one is actually broadening the methodologies by which we deliver care. So Shanthini talked about some of the community work. We can actually go a step further and say, what about if we systemize that into shared medical appointments? And we actually find a way that we can scale it. So instead of one-to-one, we have one-to-manys. There is, of course, another element, which is how do we pick which person or which consumer is going to fit best into one pattern versus another. And that's another piece of work, again, which is not currently reimbursed or supported. That's looking at the concepts of patient activation as well. So there are multiple elements, but from a purely Medicare perspective, I think it does have to mean we have to look at a blended system. It does have to be weighted towards the risk and needs in communities. And we can actually define complexity in a few different ways. Currently, I quite like the idea of hospitalization risk indices, but we can look at multiple things, but postcode has to be a part.
Prashanta, when you talk to general practitioners who are not necessarily engaged with the program, they say, I haven't got the time to get involved in case conferencing. You're now a believer. What got you to being a believer in a sense? Because you may well have started off with that kind of skepticism yourself.
So look, we involved with Professor Mallick's team since 2016. So I remember that that time case conference we used to do, the registrar consultant used to come to our practice. But whether thanks or not thanks to Corona or COVID, then we started Zoom meeting. That was a great way. We learned a lot of things from Professor Mallick's team. So that was a really good motivation for us. So with all our team, all the general practitioners, we discussed with our patient, because it was so difficult before sending the patient to the private consultant. Patient couldn't afford to see the private consultant endocrine, so it was very difficult. My training I did in West Mid Endocrine outpatient clinic, I was working there. Often I saw that it doesn't reach up to GP, general practitioner. We used to see the patient in the clinic, but we found that often patient coming back with a high HbA1c that looks like that something is not working. And in fact, I never wanted to be GP, but I love my job now. So what we learned from this case conference, this is a teamwork, and our patients love this. Especially mentioned the CGM machine, especially mentioned that case conference, and I never saw any patient of my diabetic patient did not turn up for the case conference. Because this is not a matter of what I'm doing, it's the whole team is doing. The previously mentioned the primary prevention team working hard, education is going on in the community, and that all these people are coming to us, and it's much easier for us to work with them now.
So do you feel that you've almost become a subspecialist in general practice endocrinology?
I think we can do quite, skill is significantly improved. So I can manage diabetes, I can start insulin. I know what when to reduce the dose, what to do. I can actually share all my knowledge with my registrar, which is great. I feel proud myself is because of Professor Mallick's team. And I'm really proud of being Western Sydney, part of the Western Sydney, because we are very motivated. We decided, that we have a monthly case conference. We look at our statistic data because we got a 432 patient, type 2 diabetes.
I'm impressed.
Yeah, and so we review.
How many are you beating Ken and the people with high HbA1cs? Are you doing better than him?
We actually see that every 3 to 6 months. Like I can tell you something. So last 6 months, probably there was just somewhere that the PenCat you can pull out 8 to 10, and then we looked at that. 6 months time, 8 to 10, we did.
So just to explain to people who might not understand here, there is two or three technologies now where you can actually go into the back end of your general practice and examine how patients are going without bothering the general practice and see the quality of care.
Yeah, so we saw that we reduced somewhere like a 4% reduction within 6 months. Because those from the 8 to 10, they dropped to less than 8, which is great. We used to look at the data with the practice manager, we share with the other doctors. So we say, wow, we did something, great job. And
So Shanthini, do you share that professional, if you like, excitement about what this is done?
Most definitely. I find that the CASE conference has done this. It has bridged the huge chasm between primary and tertiary care. There is so much of exchange of information that tertiary care now knows what trials and tribulations happen in general practice. They understand fully what our time constraints are, and we in turn learn and understand and get so much knowledge from them. So it's empowered us. Like I really echo Prashanta, and it's made us more comfortable, because previously diabetes management was very fragmented. If once the patient disappears into the bowels of this hospital care, we don't hear anything back from them. So now it's totally different.
My final question is that Western Sydney and Southwestern Sydney has the highest Aboriginal population in Australia. 50% of First Nations peoples go to mainstream general practice, and others go to community-controlled community-controlled health organisations. What is the challenge? And Shanthini, you've worked with the Tamil population, you've empowered them, which is exactly what Aboriginal communities do with community-controlled health organisations. How do we get it better for First Nations communities within mainstream general practice?
I think mainly it's all to do with how we got so successful in what we were doing. When I say Tamil, it's actually subcontinental, the whole thing. It's actually being very culturally sensitive, talking in their language, making them feel really welcome, that whatever they come to us, we are there to look after them. That is how we approach it. It's very tailor-made. Western Sydney is very vibrant, very exciting, but it's very multicultural. So it's exciting to live there. But you have to tailor-made your approach to the community that you're looking after.
Ken? What's your view on this, Ken?
Sorry, I think
providing a better care, a better service, more activation in the First Nations communities who go to mainstream and general practice.
So I think there's a really classic, or rather one of your first points there was quite telling, which is that 50% of First Nations people do go to the Aboriginal control centres, and 50% don't. We, in our practice, are literally 200 metres down the road from one of these art shows. So what's interesting, of course, is why someone goes to us and not to the other. And that's probably at the heart of it, which is that it's not one community, it's multiple communities. And these multiple communities, and when we think about multiple communities, we do have to, and another one of the words you've used is tailoring, we do have to tailor and work with those individuals within that. And I think the same applies for all cultural groups. So it's the same as saying Pacifica community, which is not one group. It's the same as saying any other, saying Yugoslavian community or anything else. So I think that issue of sensitivity, working with patients and patient groups, has got to be key.
Could you please thank our general practice panel?